Hi, my name is Matt Hendrickson. I'm a Vice President with DIOUSA. It's my pleasure to welcome you today to our DDA session. DDA stands for the DIO Digital Academy, and we offer the DDA in two different versions. A basic version where we walk you through actually placing an implant step by step as you optionally follow along on a typodont that we can send you if you desire, or you can just watch us go through the steps step by step, and we handle all of the basic coverage and detail of the DIOnavi surgical kits, the protocols, and every step that's required to go through and place an implant using the typodont as an example. The advanced session of the DDA, we're going to actually walk you through an actual surgery on a live patient. Today's course will be an advanced course where we'll be walking through and we'll take you from the beginning of evaluating the patient as they present, basics of the surgical plan, and actually walk you through the live surgery real time so you can see the clinician placing the implant using the DIOnavi system as we progress. Since today's course again is the advanced course, there will be some references back to items that were covered in the DDA basics session. So if you haven't been through the DDA basic sessions or the DDA on the typodont, again we encourage you to go back and watch those sessions as well. To give you a little bit of background on what DIOnavi is, DIOnavi is a world-class, literally the best in the world in my opinion, guided implant system that's going to walk you through surgical placements unlike any other guided system on the market. It's very unique because the planning is so simple and streamlined that it makes it very easy for you to upload your cases to our DIOnavi planners where we can then plan the surgical case for you. We send that case back to you and you approve it or ask us to make any modifications. And then once the case is approved, we literally send you what we refer to as a case in a box. And that case in a box is then going to have everything that you need to perform that implant placement. Even possibly right down to the implant fixture itself that are appropriate for that plan. But in that box will be the implant guide that will go in the patient's mouth, as I mentioned, the implants themselves, possibly a custom abutment if appropriate or the appropriate anatomical abutments. It will also include a drilling protocol that will walk you through step by step as you go through and place that implant. And even if appropriate, it'll include a screw-retained temporary crown, so you have everything start to finish all in one spot. It's very unique. So today's course won't really get into much about implant specifics, but it will be very specific to showing you how that DIOnavi system works to really let you do the most efficient surgeries possible, safely, predictably, with just fantastic clinical outcomes. The DIOnavi system is built using the DIO implant fixtures, which is a world-class implant manufacturer, providing the absolute best in implants and its other associated attachments. Also, DIO offers some really unique cutting-edge technologies, such as their UV activator, which is actually a chair-side UV activation system to absolutely provide the ultimate in hydrophilicity of the implant and maximize the speed that that implant integrates and is ready to restore. As you'll see as we go through this today also, the surgical guides are fit phenomenally and just provide absolute ultimate in accuracy as well. The DIOnavi system also streamlines everything that you do to the point where literally almost everything that you do is placed through the guide. So as you'll see as we go through this as well, there's very little need to remove the guide and replace the guide during surgery. Again, the end result is absolutely the ultimate in predictability, simplicity, speed, comfort for the patient, and clinical outcomes. Just a couple of small housekeeping items. We have a lot of people who attend these DDA sessions live, so because of that, if you're attending live, your microphone is muted. You will have the ability to text questions into the moderator. So take advantage of the question, chat, submit those, and we will at the end come back and do a Q&A session where we cover those questions for you. So with that said, I'd like to introduce our speaker today. You're really lucky to have a phenomenal lecturer who's going to be teaching this course, Dr. Riley Clark. Dr. Clark is a graduate from Case Western Reserve with a DMD degree. He's an implant-only dentist. He also holds certificates in IV sedation. He's a clinical mentor and lecturer and fellow at the Whitecap Institute, which is a world-renowned implant training facility in Utah. He's adjunct faculty at the University of Utah School of Dentistry. He has a master in implant prosthetics, and he's a board-certified diplomate of the International Congress of Oral Implantologists. But most importantly, Dr. Clark is the go-to expert when it comes to guided implant surgery. Dr. Clark has experience with just about every guided implant system out there on the market. In fact, he's consulted with many of the guided implant companies. He does use the DIOnavi system on a regular basis every day, so you really have a great opportunity, and it's going to be a real treat for you to have such an expert walk you through these DDA sessions today.
Thanks for that introduction, Matt. I'm excited that you're able to join us for this DDA session. Let's go ahead and jump right in. So first topic, DIOnavi technology introduction and clinical value. I'm excited to talk about this with you as I've had a lot of experience working with other dental implant companies, dental implant guide companies, different laboratories, and I've seen what's out there, which makes what I'm about to share with you even more meaningful to me and in my practice, because it really is a level above the competition. Let's go ahead and get started. I want to play this quick little video for you to get started, okay? Here's a fun little video. I'd like to go through it. It highlights some of these technology pieces that really sets DIOnavi apart. So here you're seeing an edentulous spot in the mandible. We're always going to start with a prosthetic tooth first. So a tooth is going to be placed in the virtual world, and we're going to make sure it is in the ideal geometry to match the final restoration. From there, the implant is designed with respect to the anatomical structures around that area. And then, of course, complementing the prosthetic plan of the tooth. Here you're seeing the use of a special abutment called an anatomical abutment. That's going to be key in some of the workflows of the DIOnavi system. So here's the process, the implant coming right off the 3D printer. This 3D printer is specifically designed from DIOnavi to seamlessly work within their workflow. Their implant surface, the most contemporary implant surface on the market. And now you're going to see that implant be supercharged, so to speak, with the chair-side UV activation process. This is going to enable the implant to be even more hydrophilic, lending itself to faster healing time and a stronger implant at the end of the day. Here's the anatomical abutment you're seeing, custom fit for each area based on analysis of hundreds and hundreds of formerly made custom abutments. Now you're going to see the many clinical situations that the DIOnavi system is complementary to. Anywhere from edentulous areas, anterior aesthetic cases, posterior sinus cases, you name it, DIOnavi has a great solution for it. All right, moving on, I'd like to focus in now on that UV activation for a little bit. Through this process of UV activation, the dental implant surface is removed of debris or hydrocarbons that can build up on the surface of the implant, producing a more hydrophilic implant. That's what you're seeing right here, is that process through UV activation, creating a more pure, activated surface of the implant. Here you're seeing a competition test, if you will, between two other hydrophilic implant surfaces and the DIOUV surface. Amazing to see that hydrophilic property with a chair side activation. Really, really impressive. That UV implant I'm seeing routinely placed, and 4 to 6 weeks later, ISQ readings well above 70. That's really, really exciting to offer that to our patients. They no longer have to wait as long as they've been used to, and then we can get to the restorative procedures even sooner. It's a win-win for everyone. This really is a unique thing about DIOnavi. Their guides fit remarkable. Like I said, I had worked with lots and lots of different implant companies, different guide companies and labs, and I've never seen a guide fit with the precision and the accuracy of the DIOnavi system. It's a wonderful fitting guide to see it perfectly marry itself with the anatomical structure of our clinical crowns or our soft tissue guides. It's a very, very well-fitting guide. End of the day, we can thoughtfully plan our implants, we can tweak it all we want in the virtual world, but if that physical guide does not seat properly with precision, all of that thoughtful planning in the virtual world will not translate to any type of clinical benefit. And so I really appreciate a wonderful fitting guide, really, really important to a final outcome that we're really proud of. Another unique thing with DIOnavi, when they send my surgical reports with me, I get a structure map just like this that shows me how dense the bone is going to be around the body of my implant. If I'm preparing for my drilling protocol, whether I want to undersize the osteotomy or make it a true size, if I'm considering primary stability for immediate loading, a topography map like this helps me understand what type of density we're going to be experiencing while drilling. So through a Hounsfield unit measurement in the software, we can go before surgery even happens and make some clinical plans based on what the bone density is going to be like. I appreciate that extra boost of confidence to understand what the situation is going to look like clinically. As you know, bone quality makes such a difference in our implant cases when we talk about loading, primary stability. This takes a little bit of the mystique off of that analysis of what is it going to be like. Another thing I really like with DIOnavi is their drilling protocols. They'll show up on a sheet just like this, and this sheet just makes it seamless and easy to understand what the protocol is. Not in words, but in pictures. Anyone can read it, anyone can understand it. It makes it even easier for me as a clinician to be there and to see exactly what the drilling protocol is going to look like. As you can see at the bottom, there's a D3 step where you would end after density 3, and then there's a D2 or D1 step, giving you some insight to what you might undersize your osteotomy as in preparation for primary stability. I like this. It's thoughtful, it's clever, it's streamlined, it's easy, it's convenient. That might be a theme of just what the DIOnavi system is, and this little picture form of their drilling protocol kind of epitomizes that exactness of what DIOnavi can do for you. Makes it easy and simple for you, so you don't need to think any harder than you have to. Last thing I want to mention when we talk about this is this anatomical abutment. These anatomical abutments, again, are designed from analyzing hundreds and hundreds of custom abutments. And they came up with some unique geometries, and those geometries are very complementary to soft tissue contours in the mouth. So you don't need to pay the price for a big old custom abutment, but you still get the benefit of an anatomical abutment that can go in, be very thoughtfully crafted relative to the soft tissues, could theoretically stay in the mouth the entire time, never needing to be removed, because it also doubles as a scan body. So this can be scanned in the mouth, and then from that impression, a final prosthetic can be planned. I appreciate the thoughtfulness with soft tissue. Soft tissue, we know that if we can put an abutment in early and leave it undisrupted, then with that, we will have a long-term soft tissue connection around these titanium surfaces. And so I love the idea of an anatomical abutment going in the day of surgery, staying in because it does not need to be removed for impression taking, and then being our final abutment if that's what you choose. It's a really clever abutment. It's a little more economical. It's very thoughtful to soft tissue. I think it's a very, very clever idea. They come in a variety of sizes, as I mentioned. You're seeing some of the size options right there based on anatomy, based on size and shape of the surrounding teeth and tissues. You'd select the right one from that. It's all done in the digital world, though, for you. So in the digital world, they can measure, look at that, hand select the right one for you. Just a couple of more slides I have here. This is a really cool case I did just a couple of weeks ago. What I love with this slide here is it really highlights, in essence, what the DIOnavi system does for me, for my practice, and my patients. This patient came in under 15 minutes. All of those implants went in with the guide, with surgical precision. The patient left thinking, have we even started? I love a system that lets the patient feel like they're a king or queen. I love a system that lets me as the clinician feel like I'm doing a great job for my patient, saving time, saving stress, and to get 3 implants just like that, parallel, thoughtfully planned relative to our prosthetics in a way that is efficient, good use of time, everyone is winning. My patients appreciate it, my clinic appreciates it, I certainly appreciate it as the clinician. I think that tells a big story right there. So when we talk about this technology and how does it really benefit us as providers, I think that X-ray tells the whole story right there. Maybe one last little thought. What I love also with DIOnavi, it's this idea of a case in a box. And so one case gets sent to me, I open it up, it has my implants, my guides, my healing abutment, or my custom abutment, or my anatomical abutment, with a prosthetic crown, with my drilling protocol, all in one box. In terms of organizing our implant cases, coordinating with this lab, or that lab, or this manufacturer, this really streamlines it. There's only one place, DIOnavi, I talk to them, and they get the whole thing from A to Z figured out for me, and it just makes it a lot easier for organizing our cases. I really appreciate what the case in the box can do. And so those are some of the things that I think are highlights of the DIOnavi system, how the technology benefits you, me, and the patient. I hope you enjoyed that. Let's keep moving forward. All right, welcome to our live surgery now. This is going to be our introduction to our patient. We're going to be doing sinus surgery and posterior implants. So let's go ahead and take a look at some of these slides. Here we have a 30-year-old female, good health patient, happens to be missing posterior teeth, one anterior tooth. We're excited to plan implants for her in the upper left in this video series. Let me go ahead and show you an occlusal view. You can see good broad bone. Tissue is thick and nicely keratinized over the crest of the ridge. That will be our surgical site there, just distal of number 12. So we're going to be doing a number 13 into native bone, and then a number 14 into the sinus with a small sinus lift to create a little bit more vertical space. Here's one more view of the soft tissue. You see a little bit of trauma from her removable partial denture that she wears. She's excited to get rid of this with this surgery. This is going to be a really exciting time for her. Let's jump into the CT and take a look at the anatomical structure of the bone. So here's number 13. As you can see, a kind of a weird radiolucency in the bone. So decent bone quality other than that low density area. I'm not concerned with it. I've thoroughly examined the area. I don't see any foreign body or any concern there. I think that's going to be just fine, but that is where our number 13 implant is going to go, is right there. Number 14 implant, as you see, we have a little bit of a low sinus. I can get just barely a 7 in there without any grafting. My hope is to do at least an 8.5, maybe a 10 millimeter length implant. And so we're gonna lift the sinus anywhere from 3 to 5-6 millimeters is my guess today. But you can see good bone quality for posterior maxilla. Overall, I think this is gonna be a great case. I don't see any red flags. The sinus has been evaluated, looks very healthy. I see no inflammation in the sinus. I think this is going to be a fantastic candidate for a crestal approach with our guided DIOnavi system. Let me show you a few screenshots from the planning files. So here's number 13 implant in the planning file. You can see we're very close to the sinus. Personally, that's where I like to put my implants. I like to at least gauge that inferior border of the maxillary sinus. That cortical bone is strong. In an area of the mouth that typically is pretty weak bone, I would like the floor of the sinus to be very close to the apical end of my implant, and you see we planned it there perfectly in the virtual world. And so I like that. They've indicated on my plan there, hey, we are close to the sinus wall. I feel like saying, yes, thank you, that's exactly where I want it. And so I love that for number 13. As you see, we have planned a 4x10, and the offset is 9 millimeters. Number 14 is a 5x7 right now, and like I said, I think we're gonna do at least an 8.5, maybe even a 10. We'll see how it goes in surgery. But you can see that implant is planned beautifully relative to the prosthetic tooth. You see it's just barely jumping up into the sinus, and that's when we're gonna use the sinus kit with the master kit. We're gonna jump up into the sinus, graft it with some synthetic bone, and then create vertical space for a longer implant. So that's our surgical plan for today. Those screenshots came directly from my portal on the DIOnavi website, and that's how we evaluated and made our surgical plan. I think it's a good plan. I'm excited to see how surgery goes. One thing I always like to highlight with the DIOnavi workflow is this case in a box idea. You see my surgical guide there. It's planned to do other implants later at different stages as she can manage that. But I have my surgical guide, I have my implants, I have some abutments, We're ready to rock and roll. Let's go ahead and get started with surgery. Okay, here's our patient for number 13 and 14. Again, 13 is a native bone, decent bone quality, a little bit of a low density area, and then number 14 is only about 6 millimeters into the sinus. So we're going to go ahead and do surgery right here. I went ahead and put just about a carp in the buccal and maybe a quarter a carp at the palate. I used Septicane 4%, 1 to 200,000 epinephrine, and just waiting for it to soak in a little bit. The first thing we're going to want to do on any case is to make sure we try our guide in and it fits properly. This is always an exciting thing because if this guide doesn't fit just beautifully, we can't start with our surgery yet. So I'm going to go ahead and roughly seat it, and then once I feel like we're lined up, I'm going to put some good pressure, and this one literally clicked into place, which I will take. And then my eye likes to look right around here. Make sure it's sitting nicely. Buccal contour, you're seeing same thing right here, same right over there. And if I get a mirror, you can check the distal areas as well. All these little windows are there to help you visualize the guide seated everywhere. Real big for me if you can. Beautiful. That right there is beautiful. That could belong in a textbook. Look at that. Beautiful fitting guide. No rocking or anything. Where we're going to focus right now is in this site. The fact that I see a gold sleeve means that this is a narrow implant site. The other ones are blue, blue, and so here at gold is a narrow implant site. So I love that. That fits beautiful. Give you a little more medicine, okay? Okay, the guide is seated properly. The patient is numb. I now need to refer to my drilling protocols for number 13 and 14. I'm going to go ahead and do 13 first, get it all the way to completion, and then I'm going to do number 14, okay? So number 13 drilling protocol, we'll start with a tissue punch and a bone flattening drill.
Just falls right there.
So here's our tissue punch. Again, it has a radial or radius blade here. As we tissue punch circumferentially, this will also scrape the top of the bone, getting that bone or getting the soft tissue off the bone. I love this tissue punch. Because the tissue punch and the bone flattening drill are the same for 13 and 14, I will go ahead and use those both at the same time. So I'm going to go 13, 14 here. Go ahead and turn way to your right. Way over and real big. Is that as big as you opened?
Uh-huh.
No. I'm going to push hard, roll, and out. I didn't get it just yet. We're going to go one more time. Sometimes the drill extension might be needed. If you're a right-hander going across the arch, sometimes that drill extension is needed. I'm going to go ahead and try this one. Real big for me. I'm going to push down. I like a little wiggle. Push hard. That typically does it. There's the tissue. I'm going to see if the assistant can suck that out with the suction. Beautiful. We're going to go and do the back one now. Push hard, little wiggle, push hard. Got some of it, not all of it. And there it is again. So both are tissue punched. No reason to take the guide off. Now I'm going to go ahead and use the bone flattening drill. Just to that first black line. That's plenty. A little bit of bone there. We're going to irrigate. Turn my way again. And again, just that first black line, pretty soft bone there. That looks good. A little bit of bone there. We could harvest that if we wanted. She's going to irrigate. Now, according to our drilling protocol, we're going to put our tube in, and with the tube in place, we're going to go ahead and start our pilot drilling. And again, I'm just going to do number 13 first. Okay, so here's our drill tube. This is going to go into place into the guide sleeve. Sits flush, beautiful. This is our 2x5 according to the drilling protocol. All the way to depth and out, and then we're going to irrigate in between. Next drill is a 2x10. Okay. So now we have a 2x10, real big for me. All the way to depth. Beautiful. And out. I'm going to go ahead and take this sleeve out. Now, according to the drilling protocol, it's a 2 7x5. So 2 7x5 all the way down and out. Two 7x8.5. And a 2 7x10. Now it's a profile drill, 3/8 profile, and then it's time for the implant. So this is our 3/8 profile. As a review, the bottom of the black line is what my recipe is asking for. That's the drilling protocol. So I'm going to drill this right to the bottom of the black line. Right there. This normally has a lot of bone harvesting. Good bone there. I'm saving a little bit of that bone, and I'm going to mix it in with our bone graft for the sinus. So now it's time to put our implant in. Changing my motor speed. Okay, this is a 4/0x10, and I drilled to the D3 protocol. I am not using the abutment profile drill because no abutment's going to go in today. That's it right there, right to that depth mark to get the implant all the way to the proper depth. Okay, real big for me. My motor is at 30 RPMs, 35 torque. Just about there. Starting to bind up a little bit. I don't mind that. We're going to use a hand torque and do the rest. Not getting much tighter, so I feel perfectly fine advancing this. That looks beautiful. Right there, I lined it up even though it's not needed. I'm now going to use a rongier, and I'm going to remove that. Real big. Little wiggle. There we go. Let's go ahead and take an x-ray. I'm going to take the guide off, and we'll take an x-ray of this site. Real big for me. We're almost done. Okay, that looks good. Okay, now number 14. All right, that implant looks great. I'm going to let it just sit there, and let's go ahead and do number 14. If you look at number 14's drilling protocol, it looks quite a bit different than the other one, and that's because this is a sinus drilling protocol. You're going to notice some yellow stoppers and some blue stoppers being used on top of the drills. You're going to be using your sinus kit. That's where you find those stoppers. So you're going to be using your master kit and your sinus kit, both of those in conjunction with each other. Okay, so now it's time. I've already tissue punched and I already did a bone flattening drill, as you probably remember. So I'm going to go ahead and put our surgical guide tube in, and I have a 2x7 drill with a gold 4 stopper. And if you're wondering how I knew to use the 4 stopper, you would have to refer to the drilling protocol. The drilling protocol tells you that. This is part of approach the sinus wall phase, which is phase 1 of our drilling protocol. So I'm going to use my drill tube. The drill tube is going to go in real big. And now with this in place, you can see there's only a little bit that I'm drilling with. I'm going to go ahead and drill here all the way to depth. Good. And we're going to come out. Open big. She's going to irrigate that. And then my drilling protocol next is a 2-7x7 with the 4 stopper. So the drill tube comes out. I'm going to grab my 2-7x7 with the 4 stopper on the top right-hand side of your kit. There's my stopper. I'm going to line this up. All the way down, hard push, and out. Beautiful. Next is a 3-2x7. Here is a 3-2 diameter, 7 length, 4 stopper. All the way down and up. Now it's time to create the opening into the sinus. The sinus protocol asks for a 17 drill, so the 17 sinus drill, this is found in your sinus kit, with the 3 stopper. So the 3 stopper, as a reminder, the sinus drill goes all the way down to 10 RPMs, so very slow drilling. You're going to see this is quite slow. Hard push and out.
Be the same every time. These never change.
Next step is the sinus pusher with 18 millimeter length, again with the 3 stopper. So this is essentially going 1 millimeter more. This is the drill that is going to be pushing just barely into the sinus. Real big. Only a millimeter here, really firm pressure. Beautiful. I always like to see a little bone at the apex. I'm seeing just a little there. Not there, but right there. I like that. She's going to push her water not too deep because the sinus is technically open now. Now this is the fun part of the sinus procedure. I'm going to take the guide off and we're going to use the hydrostatic pressure to lift the membrane off of the bony floor of the sinus. So this guide is coming off. Here we have our hydrostatic pressure tool. This little handle helps me actually hold the nozzle in place. And then my other hand has a syringe. There's sterile saline inside here. And I have about 2 cc's loaded up. I'm only going to push up about half a cc. They say 0.6 on the protocol. So how this works, I'm going to take this, I'm going to hold this right there, seating that properly, making sure no water spills out. My assistant, her job is to keep her eyes there and make sure nothing spills out because my eyes are going to be focused right here on the syringe. And I'm going to push about 1/10 of a cc at a time. So there's about 1/10. Then I let go. See the back pressure? 1/10 more, and I let go. A little bit of back pressure. 1/10 more, back pressure. 1/10 more, and some back pressure. So I'm almost at a half cc right now. Right now we've done a total of 1/2 cc. Gonna let it go. I'm going to lift just a little bit more. A drilling protocol says 0.6, so I'm going to do 0.6. Sometimes I do a little more, but I'm going to be a good boy today and follow the recipe. So there's 0.6, let go. Now my eyes are going to come here, and when this comes off, you might see some fluid come out. I don't right now. Let's get a mirror in there, and let's take a look. So you see our first implant placed right there. There's our opening into the sinus right there. I'm going to plug the patient's nose in just a second, have her lightly breathe through her nose, and then we're going to evaluate what's going on there. So I'm going to plug the patient's nose with the 4x4. A little air there. Go ahead and try to breathe through your nose, out. One more time. I'm not seeing any movement or anything like that. That's a good sign. I'm going to go ahead and use the next drill in our protocol and evaluate what that looks like. I'd like for you to see that water movement a little bit more. So I'm going to try to do something clever here. I'm going to get the guide back in place. Beautiful. I'm going to use this next drill, and then I'm going to do the sinus hydrostatic lift one more time, just because I want you to see that. So I'm going to go up to the 19 drill, which is the next drill in the protocol, with the 3 stopper. And with the 3 stopper, this is going to push an extra millimeter down into the sinus. Very good. Were you feeling that a little? Uh-huh. Okay, let's take some anesthetic. Let's take the guide off just because it's going to come off anyways. Try to lift straight up. I don't want it to hurt that abutment. Are you feeling any of that right there? Okay, good. I think we've got you there. So I've just drilled a little bit more. I want to just try this one more time because I'd like you to see a more meaningful visual of what we're trying to accomplish here. I think we've accomplished it, but I want you to see it a little better. So again, I create a good seal here. I come back here, and I'm going to push about half a cc worth, a little bit. That's it right there. That's another 0.6. I'm going to go ahead and take that off, and now you're seeing the water run out a little better. So watch this. Plug the patient's nose, blow through your nose. See the water run out. One more time. Okay, a little suction for her. All right, let's try that one more time. Blow through your nose. Good job. So you got to see it run out a little bit more. By creating more patency, you're just able to see the water, I think, flow through a little bit more. No air bubbles. That is called a Valsalva maneuver or a Valsalva test. I'm confident now that we can put bone into the sinus and start putting our implant in without any type of perforation there, because I did not see any air bubbles at all. So my bone of choice here, this is a beta tricalcium phosphate. It is mixed with the patient's plasma for a sticky bone application. I have 1/2 cc here. I'd like to use at least 60-70% of it. I think that's going to be just plenty. I'm going to go ahead and I'm going to use my bone packer here. My H value is 9, and because the H value is 9, then I'm going to go ahead and I'm going to use the 9 stopper on my bone packer. Okay? The H value is written on your surgical protocol at the very top. So when you find out what the bone plus gum height is, that's called your H value. Based on your H value, it determines what your bone condenser stopper height is. And again, that table is found on your protocol. Here's my 9 stopper. 9 stopper slides on. And then here's how I like to do this. I come here, my assistant brings the bone right to there. I then take it and I pack it in. I like to get a little bit in the osteotomy before I push it all the way through. There it goes. Beautiful. Let's take some more. I'm going to pack half of the bone that I just showed you on that dish. And then I'm going to take a PA. Okay. And that PA is going to tell me exactly how well my bone pack is. Starting to clog up a little, so I made sure I pushed it all the way to depth. We got that all the way to depth. If it starts to clog up, you need to get one push all the way to depth. It's just clogging up in the osteotomy. So probably one more scoop. And then we're going to take a PA. And what I'm looking for is a nice, dense, dome shape appearance of my graft material. This material is very radio opaque, one of the main reasons I use it. And it's going to show up beautiful on an X-ray. Beautiful. So I see that nice dome shape. I see the bone is densely put together. And that dense structure of the bone is one more indication that we have not perfed the membrane and it's not getting loose within the actual sinus. So I'm going to pack in just a little bit more bone, and then we're going to put in our implant. If you noticed in the pre-surgery video, I told you there was a 5x7. We're actually going to place a 5x8.5. And so we're going to make sure we have a 5x8.5 ready to go, and then we'll be good. So a little bit more bone pack.
Is there ever a reason why you wouldn't use all of the bone, like the whole half cc?
If you didn't lift it high enough, it would put undue pressure on it. Okay. Or if your assistant drops it.
I bet I can find it.
I don't want it. It's contaminated.
Okay.
Okay. So all the bone pack has been done. I particularly do not like the last visual in the bone disperse picture. I don't like sticking that other instrument and wiggling it around. And so I actually skipped that step. I'm going to go now to my final drill, a 3/8x7. So the guide goes back on. Fits like a glove. Again, I got a little extra bone down there I want to get out. My assistant tried donating that. She has to take it now. That's right. So now I'm using my 3/8x7. And there's no stopper on this one. I'm at slow speed. I'm going to keep it at slow speed just for the heck of it. Beautiful. We got all the way through. And I'm going to ask my assistant to activate my implant. 5x8.5. All right, my implant has been activated. This is a 5x8.5. There's my implant. My motor is at 30 RPMs at 35 Newton centimeters of torque. Real big for me. These posterior ones can be a little tricky. Looks like we're going to get it in just fine though. Going to line it up. Go ahead and go pedal to the metal. Sometimes you'll get extra pressure right here. Beautiful, torqued out right at the final there. I love that. Let me get that out of there and we'll get an x-ray of both these implants together. I'm sorry you're feeling that. Is that some good pressure there? Let me do one more. I want to get just a little higher. Okay, there's our x-ray. Looks beautiful. Implants look nice and parallel. You see the bone graft around our implant. What's not to love about that? Looking at keratinized tissue profile, we have good keratinized tissue, so I'm very happy with that. I think this could be a candidate for healing abutments. I want to check just one more thing, see how much bone we have around the implant. That looks great. I'm going to check torque values one time. If my torque values are 30 or more, I'm going to go ahead and elect to put in a healing abutment. Otherwise, these will be a cover screw. So I'm going to let that drop into the hex. There it goes. I've got good torque on the back one. The front one. Good torque there. These will both be healing abutments. I'm going to go ahead and irrigate out inside of these in preparation for the healing abutments. So again, sterile saline. Beautiful. And then we're going to put our healing abutments in there.
This is for number 14.
Let's take a 4x4. I have one here. Number 14. Here's a little trick. Sometimes I like putting a little 4x4 cotton back here. Acts as a little bit of a blanket to catch anything that might drop. Just about down. There it goes. Hand tight. Number 14 looks beautiful. Here's number 13. Let's get a mirror and let's show these off. So there they are. There's number 14. There's number 13. Good keratinized tissue, good primary stability, beautiful position. That is a predictable workflow with a sinus lift, mind you. Hope you guys enjoyed. Have a good one. Okay, I'd like to review with you now the post-op CT from the surgery. I'm looking here at implant number 13, and I just want to highlight a few features of the implant placement that I like, that I think really highlight some important principles that we were shooting for in our preoperative planning. So first off, let's start with the apex of the implant. I love the proximity of the implant relative to the floor of the sinus. In this area of the jaw, posterior maxilla, we know that the bone density is typically a little weaker, lots of trabeculated bone. I think it's extremely advantageous to get that apex in very close proximity to the floor of the sinus. If you look at the far right in the sagittal slice, you see even more how nicely intimate the apex of this implant is with the floor of the sinus. So that's intentional. I think a lot of strength is gained from that. That's something I shoot for every time on these posterior maxillary implants. And then with a digital protocol, with the DIOnavi protocol, we can consistently, confidently, comfortably do that without any question or concern. So I love that. Notice the buccal plate is thick, it's robust, palatal bone looks thick and robust. Obviously you're seeing a little metal artifact around the implant, which is common on a CT, but it looks like we have really good bone all the way around this implant. Another thing I would highlight, if you look at the trajectory, it's pointing right at the clinical crown of the lower dentition. So we know as far as force management, this appears to be in a really nice ideal position. Obviously that's not the most accurate way of measuring that, but it's always comforting when you see the crown down below and you know the implant's headed right at it. That's a great sign that this is going to be a good, thoughtful restoration with respect to force management. So I really like number 13. Nothing here I'd really change. You see it's a little bit subcrestal. We've got our healing abutment in there. It looks like a really tall healing abutment, but if you recall the surgery, it was just barely above the soft tissue. And so that's the right size healing abutment for the case, in my opinion. You maybe could go a little less, but I think this is the right size. So that's number 13. I'm happy with it. I like what the CT shows us. The CT is always going to tell you the real story. Two-dimensionally, everything always looks good. At least it should. Otherwise, we probably shouldn't be done with surgery. But two-dimensionally, they look really good. Three-dimensionally, you see really what happened. So I like what I'm seeing on number 13 for sure. Let's move over to number 14. Obviously, the first thing we will look at is the sinus graft. I like our graft material. I like that it's compact, it's close together. It's just another reminder that we did not perf the membrane, the fact that the graft is well contained, densely packed together. I like what I'm seeing there. A little bit of style point loss, the fact that the graft doesn't make it all the way over to the medial wall. I don't see a big clinical outcome to it being that way, but you know, I think it's going to work just fine. There is bone all the way around the implant, which is great. We lifted it a good 6-7 millimeters, which is fantastic. I'm happy with how it looks. I think you know, for full style points, I call it, it'd be nice if that graft went all the way over to the medial wall. But I'm really happy what we've done. The implant's probably in about 50 to 60% native bone, and then maybe 40-50% in our graft material. So I like what I see there from a graft standpoint. Same thing, good bone on the buccal, great bone on the palate, and then it's pointed directly at our clinical crown down below, and the healing abutment's in place. So I really like this. Again, what a thoughtful, simple procedure for us as the clinicians, for the patient, to do that type of surgery to create that kind of impact in terms of the bone graft, immediate implants, one stage, and to do it in a timely fashion, I think is awesome for everyone involved. So really, really happy with the clinical result. Again, I couldn't be happier. So it looks really, really good. With that said, I hope you like that surgery. I hope you like these post-operative x-rays that hopefully kind of bring some, you know, closure or full circle to the actual clinical case. I think what I'd like to do now is show one more clinical case, and I'll narrate what is going on, but it's another sinus case. I think seeing another one in a different circumstance might just highlight the procedure, the workflow, a little bit better. And so let me go ahead and let's play this next video, and we'll narrate what's going on in the next video. I have a video that I recorded I'd love to show you. Bear with me, it's a little bit rough, the video, but it's real, and I think you'll appreciate the realness of the video. What you're seeing here, just to set the stage, this was full mouth extractions and then placing 5 or 6 implants. These things right here are a special fix pin, we call it, that actually go into implants that were placed and help secure an edentulous guide even more. It doesn't have to be edentulous, I guess, but typically I use these on an edentulous case. And so I took out a bunch of teeth. I placed these 2 implants, knowing that I wanted to use them as anchors to help hold the guide in place. I also had horizontal anchor pins. However, there's nothing like a vertical pull down on the soft tissue to hold your guide in place, even better than a horizontal anchor pin, in my opinion. So what you're seeing here is a sinus lift on this number 3 site, And then these again are just little fixed pins, we call them, that hold the guide in place. I'm gonna go ahead and narrate this, and there's a little sound to it, but not voiceover. So here's the entire workflow. Here is the tissue punch. Notice it actually pulls the tissue up into the tissue punch, which is really nice. We reviewed that in our hands-on. Here's the bone flattening drill. The bone flattening drill just creates a flat surface on the top of the bone to ensure a really nice table for this drill that we're going to use right here. So here is my sleeve and tube. I'm going to put the tube in place, but now this is a sinus kit or sinus case, remember? So I need to grab the depth stop. So I'm probably looking at my papers there. What's the number of my drill stop? I go up to the kit and I find it and I push that on. And that is the magic, if you will. In the virtual world, we planned exactly how much space was needed, and this stop provides that. So I'm going to push this to the bone. Once on bone, then I run the drill, and I push it, come out. My assistant will irrigate between every drill for me. So I'm going to go now. I know I'm done with the drill tube, so I'm going to get that out of there. And now I'm going to switch to my next drill. It's a 2.7 by 7, or by 5 it looks like, and then I grab the yellow depth stop. And how did I know that? The drilling protocol tells me that. So now we're going to drill a little bit more. Simple as that. I edited a few seconds of just my head moving between drills. Otherwise, what you're seeing is complete real time without any big edits. I wanted you to see what this procedure really looks like in terms of real time. I'm not rushing here. This is just normal working speed. So here's the next drill, a little shorter depth stop. So I'm going to get down at least another millimeter here. And now I believe we'll see, I've got one more drill. This is my 3.2 diameter drill. I'm stilling that depth stop again, following the recipe that was given to me. Just widening the osteotomy now to 3.2. With the osteotomy now at 3.2, I'm going to go to the sinus kit and grab my sinus drills. I'm just checking to make sure it's the right length. This is the 17 length with a depth stop. Looks like the pink one's the right one. And this is extremely slow speed. So I'm going to take a second here to change the speed on my motor. That's what the delay is right here. And then with the speed slowed down, we're going to go ahead and run this. And this is almost just pushing the bone, if you will, very gently to gain access to the sinus. So that should be just barely to the sinus, really slow speed. And this next one is the one that's actually going to push through, if you will, and actually gain access to the sinus cavity. And so this is a little bit longer drill or just a shorter depth stop that does the same thing for you. And you'll probably see this kind of push and drop. Not so much of a visual there, but now I know I'm in the sinus per the drilling protocol. Obviously, when you irrigate, I don't want that needle tip pushed very deep into the sinus cavity at this point. Just barely put that in, just a little irrigation. I'm removing these fixed pins to remove the guide so I can do the hydro lift here in just a second. I'm now securing the tubing to my sterile saline syringe. And then I'm going to grab the membrane lifter. I'm going to put the handle on it and then hook up the tubing. And just like you saw in that other video, I'm making sure I've got water primed on it. I've got to prime the pump. And then I'm going to seat this. And I wiggle this around a little bit so you can see you don't want to be too tight with this. Otherwise, it will kind of bend and flex. So just enough where you get a seal, and your assistant can be extremely helpful to make sure you have a good seal, because I believe your eyes should be on the syringe watching what you push. I think that is more important. Just a good steady hold there. And then that scared me right there. It kind of pushed through and I didn't feel any back pressure, but I didn't perf. thank goodness. But did you notice it kind of went a little bit quick there? And so now I'm just slowly pushing, getting to about 0.6 cc's. That's what my drilling protocol recommends. I went a little bit more than that. I like at least 0.8, maybe even 1 cc of total volume. Now check this out. Here's the nose test. No bubbles. I'm seeing the saline, but look at, I see the little hole. There is certainly no perforation. That's a beautiful video there to capture that. That's probably the best part of my video there. I should have stopped it there because now the rest gets a little blurry. I have to do one more drill to create even extra patency so that I can pack my bone. So I'm going to go ahead and run one more drill, and now it's even more patent at the end. And now here's bone packing. This is sticky bone. So I drew some of the patient's blood, spun it for just a couple of minutes, took that serum layer, injected it into my beta tricalcium phosphate. And now, once I get the patient open, I'm going to take that bone and push it on. Notice the depth stop again on my bone packer. There's a purple depth stop there, and I apologize for the blurriness there. This camera's a little new for me, and I didn't do a great job here, so bear with me. It gets a little better here. But I'm going to pack the bone in, and I will say this step right here, although I think it looks kind of easy, it is where most clinicians stumble a little bit, and they make this harder than it needs to be. This opening is only 3.2 millimeters, which is a little bit smaller than what a lot of people are probably doing when they're doing crestal lifts. You typically are opening to your final diameter and then lifting. When you have an opening that's only 3.2 millimeters, packing the bone can sometimes get clogged. And notice how I take this to depth every couple of pushes. So I'm pushing a little bit, and then I will take this all the way to depth here in just a second. And that's right there. And that's really important to create true patency through that osteotomy. If you don't do that, you will clog that area up. And by clogging it up, it gets extremely frustrating, and it's kind of nerve-wracking. So that's a cc of bone. And I typically place half of it and then take a PA, and I determine if I want to place any more. I was filming this. I went ahead and just placed all of it. You're going to see this takes a little bit of a second, but I placed every bit of 1 cc, and then I put the implant in. I felt like we had a good lift, but you're going to see in a second, I probably put even more bone than we needed in. I should have done a longer implant, might be my regret on this case. But you're going to see I went ahead and I'm packing bone, again, making sure I push to depth, and that depth stop is ensuring I don't push too deep and hurt the membrane. A little bit more bone. Again, I didn't want to edit anything out. I wanted you to see this whole thing in real time, and so this gets a little repetitive here. But we're going to pack more bone. Isn't that sticky bone nice for handling? If you aren't using sticky bone, you probably are like, that looks a lot easier than it should be. And if you just have loose particles, oh my gosh, they go running everywhere. About half of it makes it into the sinus, and the other half gets sucked up through your surgical suction because they fall to the back of the mouth. And so that sticky bone is amazing. I mean, even though, I mean, it has obviously some biologic properties, which is fantastic, but you have to wonder if even the physical properties are even just as impressive, I should say, because handling the bone like this is just so much easier than different methodologies. I've used the different bone trumpets and amalgam carriers and all those different techniques. Nothing's better than just sticky bone on into my periosteal elevator. And I just bring it to my surgical site and then pack in just like you're seeing. Okay, so done bone packing. Now I'm putting the surgical guide back on. I want the guide accuracy for the implant. And so I'm going to load up the dental implant here in just a second. And then we're going to put that dental implant in. So there's our dental implant, loaded it up. This was a 5 by 8.5, I believe. It might have even been a 5.5. No, I think that it's a 5 by 8.5. Sorry again that it's a little blurry there, but you see it going in. There's those little tabs at the top of that fixture driver. Those are depth stops. I want that to be flush with the surgical guide. I'm now maxed out at torque, and I'm just kind of hand cranking it. You always get a little excessive torque reading because the guide and the driver friction. And so I don't mind doing a little hand pumping there to get that down a little further. So I'm going to take one more view at it. There it is in place, and that's the surgery. That's real time. So I think we were about 10 minutes on that case, start to finish, in terms of that single site. Obviously, I had the whole mouth or the whole arch to do. But that's awesome. 10 minutes, 12 minutes for that procedure, start to finish, very predictable. And hands down, where I spent most of my time is just packing the bone. The other parts of the process are pretty straightforward. How neat to use technology and take a procedure that can be a little bit more ambiguous, a little bit more maybe challenging, and take it and make it very, very straightforward and simple like that. That's phenomenal. Here are my post-op CTs on this particular case. So this is the case I just showed you. I packed a lot of bone. We should have probably done a 10 millimeter length implant there, maybe even an 11.5. But again, I knew I was filming this, and I kind of just wanted to show you guys, look at that bone graft. I measured it from the top here. That's where my sinus ends. So the graft was 8.2 millimeters of lift. And so really nice lift there. To do that with a crestal approach is phenomenal in my opinion. Obviously, some of that will come down just a little bit, but that's a great bone fill right there. Again, that's a clinical case that I appreciate in terms of my contribution to it. The stress, the workflow for me is awesome. The patient to have a service like that is just phenomenal as well. They're always really impressed, if they're not sedated, how quick these procedures go. They're expecting some big extended surgery, and that's just not necessarily what implant surgery is today. There can be cases where it's like that, but under the right circumstances, these are pretty straightforward. I chose to put a cover screw on here. I didn't love his soft tissue profile. I felt like I could move some keratinized tissue later. I don't know if you noticed that there wasn't a lot of keratinized tissue. So I'll do an apical repositioned flap later on this case, and that's why it's a two-stage approach in this instance.